11:27 Eastern Standard Time. We're getting ready to begin our second spine surgery for the day. This surgery will be broadcast live, as are all of our surgeries from Deuk Spine Institute. The patient comes to us from Canada. She has a history of back pain and left leg pain. The pain is debilitating in her back and left leg. It's been going on for some time now, and you can see on the MRI she has a herniated disc at L5-S1. The actual protrusion outside of the disc is what compresses the nerve root and irritates the nerve root, causing her leg pain. And the tear in the back of the disc, called the annular tear, is the actual source of her back pain. So we're going to go in and fix the back pain and the leg pain today. It is an L5-S1 disc problem. She is a larger patient. Body habitus is big, but that makes the surgery a bit more challenging. Also, L5-S1 makes the surgery more challenging. But I'm hoping that everything goes well and expecting it to go well. L5-S1 is the hardest disc to treat, transforaminal approach, and the few endoscopic spine surgeons in the world that do endoscopic spine surgery, they do it on the lumbar spine, but they rarely go transforaminal at L5-S1 because it's so hard to get to. They usually go interlaminar, and that means they're removing the lamina bone, which is the normal bone of your spine, as well as normal ligaments. So it's not something you want done. That's why I don't do interlaminar. I do transforaminal, because transforaminal is safer and it doesn't cause any damage to your spine or any of your soft tissues around your spine. It's basically the best way to do it. It's just technically very hard to do. And that's why most endoscopic surgeons, there aren't many of them, but all of them, they don't do transforaminal L5-S1 because it is so challenging to do. But we're going to go for it. I feel good about it. I think we're going to be able to get it done. But you can see the MRI on the right side of the screen with the big red arrow. That is the L5-S1 disc herniation I've been talking about. You can see it's sticking out the back of the disc, hitting the nerve roots. So we're going to get started in just a moment. In the meantime, Diego is going to run probably some videos, animations, so you understand how herniated discs cause back and leg pain. And then the second animation will be the surgery we'll be performing today, the Deuk laser disc repair endoscopic surgery, and how it works and what's done during the surgery. If you have questions, feel free to type them up. I will answer them during the surgery for you, and I'll answer them live so everyone has the benefit of hearing the answers and learning from the experience. Right.
Disc herniations are a common cause of chronic back pain.
Once I enter the operating room, I'm going to head over to the operating room now to get scrubbed in and get this case started.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing
You let me know if it's uncomfortable, okay? I just don't understand this local. It's just...
You know, I was working with a pain surgeon who had the same.
Huh?
I was working with a pain surgeon last Thursday.
Yeah.
Same problem. It's just burning everybody.
Well, what I think is happening is, I think that the pharmaceutical companies are outsourcing the manufacturing of these drugs to other countries. And I think that instead of putting the active drugs in, they're using water, saline, because it's, you know, they're making more profit that way. It's basically a scam, but I have no way to prove that. But the kind of people you outsource to are crooks, the ones I'm thinking of, which I won't mention any names.
He had the same problem.
Yeah. And we have very little control over our supply chain because it all has to be FDA. Like the FDA really cares. All right, we need to drop the table a smidgen. Probably 1/4 inch. You okay? Good. Shot? There we go. Now that's what we're aiming for, is L5-S1. That's the bottom disc. And so far the trajectory looks pretty darn good. You're going to be okay. Just relax, okay? No, we got to make an adjustment. Shot. It's looking more promising. Shot. Let's get an AP. Let's see where we are. So to navigate to the bad disc that's causing her problems, I have to use a combination of front, back, and side-to-side X-ray images. And I think you're off, by the way, on the lateral. Yep, actually it's looking pretty darn good. Let's go back to the lateral. So you can see the tip of our needle is very close to the spine, where we need to be. It's actually closer than I thought it would be. All right, do you see how there's a double shadow on the back of the sacrum right there? We need to change the orbit. I think you have to go the opposite way of which you went. I think that's definitely better. Let's see if we can even make it a little bit better. Just try to go a little more and see what happens. We may have passed the place we need to be. It's kind of hard to tell. I think we're getting farther away from where we need to be. Let's go back the other direction. Shot. All right. Let's try an extreme to another extreme. Let's go up, up on your side, up, up on the orbit, crazy orbit. That's it. Take a shot. Huh. Doesn't that look better? In some ways it looks better. Like with the iliac crest, it looks better. But in the other ways it looks worse. Like L5, you can now see a double shadow on the pedicle. So let's go back the other way. Stop. Oh, just don't go too much. Just a little bit. About 2 degrees. Shot. That's better on the orbit. I'd say a slight, maybe 1 degree more. Let's see what happens. Huh. I think that's, let's go back again. Shot. I think that's going to be as good as we're going to get it. Unknown caller? So basically, folks, what's happening here? We have a patient laying here. We cannot see her spine. We know it's in this area, down inside, but we can't see where to go. So we use a machine that takes a picture of the spine and shows it to us in real time, not really three-dimensionally, two-dimensionally. I have to use my mind to reconstruct three-dimensionally. Are you okay? All right, just relax. This is the worst part of the surgery. I apologize. Okay, but everything is going really good for you. Just be patient. Shot. pretty happy with the trajectory. I think we're a little too medial. Sean? Oh, we're so close. That's perfect. I mean, it's a good start, trust me. Oh, there we go. That's beautiful. Sean? Yes, that's what I like to see. And AP. So, everything's going well, by the way, okay? I know you're not happy about being awake right now, but I need you awake to help me. That's perfect. Perfect, perfect, perfect. So that's perfect on the AP X-ray. Lateral is perfect. We're actually, it's better to be lucky than good, I always say. And we've had some luck this morning, this afternoon, I should say, since it is after 12 o'clock. All right. Good. So. Where do you feel that? Okay. Now, can I ask you a question? Because you've done so well and everything is going perfect for you, okay? You've come from Canada, right? Where in Canada? Huh? Toronto. Oh, I love Toronto. That's one of my favorite places, but I haven't been to many places. So if I come to Toronto, are we going to be friends? Hopefully. That's an honest answer, okay? I don't blame you for saying that. Depends on if I fix your back, right? All right. So let me ask you a question. How much of your pain is back pain versus leg? Like what percent is back versus what percent is leg? 95 is leg. When did your leg pain start? August? August of this year? 2020. Oh, 2020. So you've been dealing with this for over 1 year. Wow. All right, folks, why does she have leg pain? Because what she has here is a herniated disc. She has a tear in her L5-S1 disc on the left side. The jelly has moved from being in the middle of the disc where it's supposed to be, and some of that jelly is pushed out through the tear. Well, guess what? She's got nerves coming down, and that nerve that goes down her leg is actually being crushed. Yeah, it is being crushed, but also irritated right here, okay? So I'm going in there to fix that with the laser. Now, she does have back pain. Before your leg started bothering you, did you have just back pain? I'm sorry, yes? Okay, but you did have lower back pain before you had leg pain. So she had a tear and a herniation, and that's where her back pain was coming from, this L5-S1 herniation. How do I know that? Because she doesn't have any other herniations. This is the only one. All right. Do you still get that back pain, or you've pretty much been so inactive you don't even get the back pain that much? All right, good. How bad is that on a scale of 1 to 10? How bad is that on a scale of 1 to 10? What did she say? 10? Is that where you got your back pain? Is that where you got your back pain? What did she say? Is that the area you got your back pain? All right. Well, we found your bad disc, and we're going to fix it for you. Will you show them the tear with the arrow? Right now, you get to go to sleep because we're going to start your surgery. When you wake up, your back pain will be gone, and so will your leg pain. All right, everybody see the white arrow? Are you showing the fluoro picture there?
Yes, they are seeing the fluoro.
All right, that white arrow is showing the tear and the herniation. I want you to count from 1 to 100 for me, okay? Out loud. In Canadian. Keep counting. Shot. Keep going. You're doing really good. Shot. All right, I've got to find the guide wire on the lateral. You all right? Shot. And I'm trying to move it to the front of the disc, inside the disc, so I could see it. You're doing great. Keep counting. There's a reason we have you counting. We forgot how to count in English, so we want you to reteach us. All right. So when people have more mass, it's harder for the x-rays to get through, but I feel very confident that the guide wire is where it needs to be based on the lateral. And I'm going to back out this needle that I use to get into the disc. And I'm going to leave the guide wire there. So the reason it's hard to see, Sean, yeah, there it is. I can see it now in the front. The reason the guide wire is hard to see is because our patient has a lot of soft tissue that the x-rays have to penetrate. So the more soft tissue people have, the harder it is to see the image of the spine, and you need a little bit more radiation to get those good pictures. We have the very best x-ray machine in the world. It's a Siemens flat panel, Arcadis Advantic. You can't buy a better x-ray machine. It's German manufactured and German technology. Our incision is 7 millimeters. Next, I'm going to bring this dilator down over the guide wire into the L5-S1 disc space. So earlier we talked about getting to the L5-S1 disc space. It's hard to do, but we were able to get in there fairly easily with her. Shot. Now I'm bringing the dilator down. I can feel the fascia. So everything up to this point has been soft tissue, adipose tissue, and now we're getting down to the fascia. And I can feel this going through the fascia. Now we're going to pass through her paraspinous muscles, and we're not going to damage them. What we're doing is we're spreading them open. Shot. Now, why would we spread the muscle open? Well, we got to get past the muscle to get to the disc herniation. So I got to get past it, and that's what we're doing. We're just gently spreading it open. Unlike open surgery like a microdiscectomy or a laminectomy where you kill the muscle during the surgery, we are keeping the muscle there. And that's one of the advantages of this type of surgery, is that you don't destroy the muscles or the joints or the bones of the spine that are normal. Unfortunately, all the other types of spine surgery in the world do. They destroy the muscles and bones and joints. But we're not going to destroy anything at all. As a matter of fact, all we're doing is gently spreading open the tissues to get down. Just lay still, you're doing good. So the only thing we've done to damage her is that skin incision. I'm talking about this skin incision right here, 7 millimeters. That skin incision is the only damage to her body from this entire surgery. The rest is going in and fixing a tear and a herniation. All right, looking good. Shot. We are inside the disc. I'm going to take the guide wire out because I don't need it. And just going to finish getting in. Shot. You want to go about 2/3 to 3/4 of the way to the front of the disc. We're there. At this point, we've lost 1 drop of blood. Now, the whole surgery, folks, is going to be done with this tube. It looks like a McDonald's milkshake straw, but it's not. It's actually a German engineered surgical tubular retractor that we use to go down into the disc so I can do the surgery. Now, once I get this docked in position within the herniation, I'm going to take the dilator out because we don't need the dilator anymore at that point. You're doing great. The outer diameter of the tube that we're leaving in to do the surgery is 7 millimeters. You want me to wait a little bit? She's doing great, but she's wiggling just a little bit more than I want. Shot? You're doing great. Everything's okay. Shot? Yeah, you can see the dilator came back a little bit because she's Valsalvaing. And when you Valsalva, you actually put pressure on your disc, and that makes the pressure of the disc higher temporarily with that Valsalva. So it can actually push the dilator out. And that's something, if you do this kind of surgery, you always got to be watching for. You cannot keep going if your dilator comes out. So shot, I got to push it back in and then bring the tube down over it. So you can see it pushing out. You see this? Look at that. I want you to see this. Look down here.
We see.
I want you to see this. This is really interesting. Okay? So look right here. See that? Zoom in on it.
Yep.
Let me know when you're there.
Yeah, we're there. We've been watching the whole time.
All right, so look at this. I'm going to let go. You're going to see that her disc is literally pushing this out. Okay, well, she's more calm now. She's not bucking as much. Okay, but it was literally getting pushed out like that. Okay, what pushes it out is the pressure inside the disc. Now, why would she have so much pressure in her disc? Well, she has inflammation in there. Inflammation causes swelling. So that's why she has so much pressure. And then on top of that, she was like tightening up, and that causes more pressure inside the disc. That's already too high to begin with. So it causes her to push that dilator out. Look at that right there. You see that? That's high intradiscal pressure. Shot? All right, now I'm going to bring my dilator back because I think we're in good position. It's so hard to tell because unfortunately there's a lot of soft tissue, which I can't control. Shot? It looks good. I think it looks good. I think it looks really good. So, folks, dilator's out. This is called the dilator. Look at the tip of this thing. It's tapered. It's really gentle. It doesn't damage anything in there. It literally just spreads it open like that. Spreads it apart. So we're not damaging the fascia. We're not damaging muscle. We're not damaging anything with the dilator and the tube. We're literally just spreading it apart for the surgery, and then it comes back. That's why there's no bleeding, there's no scar tissue from the surgery, except for the skin. The skin is the only place. How's she doing? We're done with the stimulating part for now. I need to get in here. Okay? Here you go. Luis, come on. You're dancing around like a Mexican jumping bean. Anybody ever see a Mexican jumping bean? Huh? Remember when we were kids, they were so popular? I don't think kids know what Mexican jumping beans are anymore. I don't have irrigation. Why not? You guys want me to beg for things here? Irrigation. Oh yeah, there it is. All right. Any questions from our audience?
We have a question from Facebook. They want to know if this is outpatient surgery.
They want to know if this is what now?
Outpatient surgery.
Outpatient surgery. 100%. This is outpatient surgery. Yes, it is. This patient's going to go home. Actually, not their real home because they live in Canada, in Toronto. But they're going to literally leave our surgery center 1 hour after surgery. Less than an hour. They'll be up walking around, ready to go. Okay? This surgery, folks, is not done in the hospital. There's no reason to do it in the hospital. We don't do this surgery in the hospital. Why? Number one, hospitals are more expensive. Number two, hospitals have COVID-19. Okay? Nothing against them, but that's where COVID patients go. So would you want to go for back surgery and get infected with COVID-19? I wouldn't. So there's no reason to go to the hospital. There's no advantage to go to the hospital. This is a non-hospital surgery. It's minimally invasive, outpatient, and it's done at Deuk Spine Institute. Deuk Spine Institute is the only place you're going to get this surgery done. Why? Because we do things different with this endoscopic surgery. It's not just endoscopic spine surgery, discectomy like other doctors do. we do what's called an annular debridement on top of the discectomy. And the annular debridement is done with the laser. So if you watch endoscopic spine surgery being done around the world, that's similar to what I do, but it's not the same. They use the grabbers, the metal grabbers, and they usually do not use a laser. The laser is absolutely necessary to do a debridement, an annular debridement, okay? So if they don't use the laser, they're not doing a debridement. Of course, the laser costs more money. A lot of doctors don't have one. They would love to have one. They don't want to pay for it. Come on, come on, come on, come on. Wipe it. Let's go. Haven't you seen Luis do this before? Guys, this is like, come on. Wake up. Don't make your ignorance be my reason for not having a good surgery. You've watched me do this before. When I pull the laser fiber out, what are the things I'm going to do? Huh?
I'm either going to wipe it or I'm going to give you the grabber.
You're right. Smart. So you not use your brain. You understand?
Yes, sir.
So how do you know the difference between what I want to do with this laser fiber when I take it out?
I look at the screen.
Nope. Okay, let's try again. Watch what happens. Wipe. Where is it? Right here. Pituitary, I hand it to you. Do you see the difference? It's obvious. Okay? So you just have to think and be prepared for either option.
Yes.
All right. What we're seeing here is the nucleus pulposus. It's blue, and it's stained blue because I put a dye in there called indigo carmine. And indigo carmine will bind to acidic nucleus pulposus. And why does nucleus pulposus become acidic? Because it's degenerating. How does it degenerate? Because of the annular tear and the inflammation going on inside the disc. So the reason we're seeing so much blue staining of the nuclear material inside the disc is because it's degenerating. So that annular tear that she got years ago that she's had back pain from, that annular tear has just caused a smoldering fire to keep going in her disc, which is then allowed recently, about a year ago, for a large herniation of that degenerated nucleus to come out. And that is the pathophysiology of herniated disc, degenerative disc disease. You heard it for the first time from Deuk Spine Institute, because we're the ones who elucidated the pathophysiology of this disease. You know, the gunpowder was discovered by the Chinese. You all know that? At least that's what we're taught historically. Every discovery, whatever it is made by somebody somewhere. And you're seeing the evolution of treatment and discovery of herniated disc treatment, because nobody else in the world has figured out how do discs degenerate, what causes herniations, what allows herniations, and the answers were always there. Just nobody really figured it out until we put it together here at Deuk Spine. Okay? I'm just adjusting my focus of the scope. Okay? And the reason I am is it looks a little bit blurry to me, so I want to make it better. That's my grabber right there. That's a piece of herniation. Any questions from our audience?
Yes, we have a question from a Facebook group. They ask, is muscle loss called, can an SI joint
I'm so
issue?
sorry. Your
Can you hear me?
voice is just, it needs 10% more.
Can you hear me better, doctor?
A little bit better, yeah.
This better?
Oh, yeah.
Okay.
Love it.
So, can SI joint issue cause muscle loss?
Can a sacroiliac joint issue cause muscle atrophy or muscle loss in your leg? I assume.
They just said muscle loss.
Like muscle loss in your lower back or muscle loss in your leg?
I will ask him.
There's a difference, okay? Sacroiliac pain can cause you to lay around in bed all day and the couch because it hurts so bad, and then you're going to get atrophy of the muscles in your lower back. But it will not cause loss of your muscles in your leg, like your calf or your thigh, okay? Unless you're really just laying around all the time. So loss of muscles in the leg indicate a pinched nerve, usually a pinched nerve. It could be also a muscle problem, okay? Like a muscle problem, but muscle problems are very rare. Like a myositis or a myopathy. Those are rare conditions. But if you're losing like your calf muscle, your thigh muscle, that's not coming from sacroiliitis, period. That's coming from a pinched nerve most likely. You need to have that evaluated by a neurologist. They need to do a nerve test. Now if you're talking about muscle loss in your lower back, like around your spine, that comes from not being active enough because your back's hurting too much from a sacroiliitis. That make sense? So it's two different areas of muscle. They have two different causes.
We have another question.
By the way, the questions are great questions. I love them. Keep them coming. I'm here to answer your questions.
All right. We have a question from YouTube. They're asking, being the patient is from Canada, how do you follow up appointments like physical therapy?
Yeah, so being that the patient's from Canada, how do you do follow-up appointments? Well, believe it or not, nowadays there's what's called telemedicine. And we do that with Zoom. We used to do it with, what was it called? Skype. We used to do Skype calls. Now we do Zoom calls. So everything's possible with Zoom. There is no follow-up, just so you know, with these surgeries. They're literally in and out. We see the patient the next day. So she'll come into the office tomorrow. I'll follow up tomorrow before she goes back to Canada. And that's the only follow-up people need, 95% of the time. There's a small number of people who end up having like other aches and pains from their facet joints or their sacroiliac joints or their piriformis muscles. Sometimes they get aches and pains because they bend over and they tear a muscle, or they aggravate or irritate an inflamed joint that has arthritis in it. And then they call me and say, hey, I got this pain, but it's not coming from the disc problem, it's coming from something else. And so I'll manage that with them over Zoom. If they want to come back, they're welcome to. We never keep our patients from coming back. They're always welcome to come. We have an open door policy for them. So telemedicine is the answer. But she's not going to need any follow-up with me. Is she okay? So how do you get herniated disc fragments inside the disc? Well, remember, we put the dilator through the tear, right? We put it literally through the herniation to go into the disc. And so that's how you get herniated disc fragments back into the disc. That's one of the advantages of this particular surgery, is that I can remove the herniated disc fragments where it's safe, inside the disc. So they used to be inside the disc, they got pushed out, they became herniated fragments of nucleus, and then I just push them back inside the disc where it's safe to remove them. And that's what I'm doing. I'm cleaning up the degenerated nucleus material and removing any herniations that are within the disc itself. Now this herniation to me looks relatively new. There is some areas where it's old scar tissue from years ago, but remember, her leg pain started about a year ago. And this stuff that I'm working on right here is definitely more recent. This is a huge tear in the disc right here. All this blue stuff I've been zapping away, and the annular tear is right there. That's the annulus fully scarred up from the tear and the herniation causing inflammation. Anytime you tear a tendon or a ligament, you get inflammation in that tendon and ligament. The inflammation is the first step in healing. So why do these things tear and not heal properly? Well, the answer is simple. Because with a torn tendon or ligament, you just tear the tendon and ligament. There's nothing stopping it from reattaching it to itself. But what's stopping the annulus from reattaching when it tears is the nucleus material from the center of the disc. It's squeezed out through the tear, and now it's blocking the tear from healing. The annulus and the nucleus are two totally different substances. Okay? The annulus is the white stuff over here. It looks kind of grunged up because of all the inflammation has caused some hemorrhaging in there and some calcifications, making it yellow looking. But right here, this vein of blue is the herniation, and that's keeping the annular tear from healing. Okay? And that's what I'm fixing with the laser. I'm removing this herniated material to allow the annulus to re-heal. Once we're done with surgery, the healing starts immediately, like the same day. And it will not be healed, though, for a full year. It literally takes 12 months to fully heal this annular tear. Why? Anybody know why? I've said it before. Simple. There's no blood supply here. This disc doesn't have a blood supply. Just on the outside of the disc is there a blood supply. Now, with chronic disc injuries, the blood supply can actually grow down into the disc through scar tissue formation and granulation tissue. That happens. So you can actually get a blood supply to the middle of the disc over years and years of chronic inflammation, creating a blood supply. Did you all see that movement? That was her Valsalva a little bit while she's asleep. She's probably a little coughing or gagging or something, and or bucking. And that causes the pressure to increase in the disc, and you can see things kind of move differently at that moment. I don't know if you could appreciate that, but I did. But I can also feel her moving against my tube, her body moving against the tube that's in there. So I can actually feel her, and I can see a visible change in the way these tissues move from her Valsalva, from her abdominal pressure increasing. That's what a Valsalva is. All right. When you cough or sneeze, you Valsalva. So when you gag, you Valsalva. I don't make this stuff up. Just about done with the tear, and then I've got to go make sure we got all the herniation out. And this is right here where the herniation is. Okay, that's part of the herniation right there. It's like the bottom of the herniation. Do you have a question?
Yes, we have a question
There she goes. She just coughed. Do you all see that heave? Everything's good. You're doing great. I say that just in case she's awake. I want her to know everything is okay. All right. Well, the good news is we've gotten rid of this herniation, so I think she's going to do good. What's the question?
We have a question from YouTube. Why do university hospitals not do the surgery? I thought they were the ones with the newest technology in medical care.
Ah, I love it. You just want to bring out the brutal truth, don't you? So the question is a very good question. Why don't university hospitals have this technology? Well, I thought they were supposed to be the leaders. You're right, they should be, and that upsets me too. As a matter of fact, when I had to go learn this on my own, I was really disappointed that I hadn't learned it in my residency. Is she okay? So the answer is this: it's all about money. The truth is that if you're not doing this surgery, you're doing fusions, and fusions pay much more than laser does. The bills for fusion surgery will be somewhere around $150,000 US. The bills for a microdiscectomy will be around $45,000-$50,000. The problem with microdiscectomy is it's damaging. So why are these hospitals and universities not doing this? Number one, they're going to make less money, a lot less, with these surgeries because we're not putting metal in. And you know, the metal bill for a fusion like this is going to be around $12,000 for one level. So that's just for the metal. Now, the companies that sell the metal, they're actually buddies with the teachers at the universities. You see, what they do is they go to the university and they meet with the professor that teaches the residents to do surgery. And they say, hey, Dr. Pat Jacob, you're such a good surgeon. We'd love for you to be one of our advisors. We're going to pay you to just give us advice on our screws and rods and help us make them better. Oh, really? How much am I going to get? We'll pay you $100,000 a year. Easy money. Oh, wow. What do I got to do? I'll just have a meeting or two once a year with us, teach a course, how to put some screws in. Wow, I like it. So it's basically an inbred corruption in the spine world where the teachers at the universities are on the payroll of these companies that sell the screws, rods, cages. And they are getting a lot of money. I mean, literally, I was almost fell over when I heard how much money they get. I was not, I mean, I could have been offered that. I could have been involved in that, but I chose not to because I thought it was corrupt. And it is corrupt, by the way. Another example, Dr. Juan Uribe, U-R-I-B-E, look him up. He's a big spine surgeon for a procedure called the XLIF. XLIF. Now, he was at Tampa, and he was teaching the residents to do the XLIF procedure. All right, where you're putting in metal, screws and plates and things like that, making a lot of money for the implant companies. And so they, of course, made him an advisor and made him a teacher, and it's all political. They control the politics of spine surgery and neurosurgery. If you go to the neurosurgery meetings in the United States, the spine companies dominate the meetings, and they literally pay anywhere from $1 million to $5 million for a meeting for over 3 or 4 days, just to be represented there, to be a gold sponsor or a platinum sponsor. Now, these meetings are run by the people who run the universities. So it's an incestuous money profits organization. And in the end, the patient is literally, I mean, I don't know, how do you call it? It's like a milking cow. They're milking the crap out of you and your insurance. So that's number one, money. Number two, this surgery, I make it look easy. It's not easy. And you have to have all the equipment. It costs millions of dollars to buy this stuff. Each of these scopes, for example, run around $12,000, $13,000, $14,000 just to buy one of these scopes. And you get your feet wet during the surgery. So that's kind of annoying as a surgeon to get your feet wet. Kidding about that part, but I do get my feet wet. So it's about money, and then it's really hard to do the surgery. It's not easy. I make it look easy to you all, but it's not easy to do. So you literally have to learn this stuff. It took me a long time to learn it, but I was committed to the process of doing it. At the time I was doing fusions, I was getting paid a lot more money to do fusions, but I recognized that we can't keep doing fusions forever. You know, we need to move past that. And of course there's artificial discs, but who wants a metal disc in their back? You don't need it. We just go in there like this and we fix the problem. All right, take that. Let me have the grabber. That's fine. So the answer is money, corruption, I guess bribery, legalized bribery, maybe. And then it's difficult to do these surgeries. I make it look easy, but it's not easy. And then the cost of the equipment. So there's a steep learning curve. Oh yeah, baby. There's a steep learning curve, technically, for a surgeon to learn. There's a, come on, where's my irrigation? Fucking unreal. That's it, you got it. I know. All right, the surgery is easy to do for me, but the irrigation is the hard part. No, really. This is part of the herniation right here, by the way. I'm literally jiggling it out. Oh, come on, come big fish. I'm literally pulling the herniation out. It's in the roof up here. Ah, are you kidding me? Why do we still have irrigation stuff going on? I'm about to keep getting sets of bubbles, meaning that you're tapping into a new bag. All right. So the equipment is very expensive. It's not at hospitals. They don't have this stuff. They may have an endoscopic unit, but they don't have the tubes. They don't have the scopes. They may have the cameras, but this is a high definition system. It's much more expensive than a cheap old endoscopy camera and system. This is the top of the line system. So you can see the details you need to see. So I had to buy all this with my own money. But I was willing to do that because I quickly recognized this technology was amazing. And it was the future of spine surgery. Even though the universities aren't keen on it, and even though the American Association of Neurological Surgeons and the Congress of Neurological Surgeons and all the neurosurgical societies around the world are just in bed with the implant industry that manufactures screws, rods, cages, I recognize for patients' best interest, the patients would want this surgery. The patients don't want their surgeons and the implant companies in bed together making profits off putting in screws and cages into their spine. Patients want what's best for patients. And this is what's best for patients. So that's why I did it. Because in the end, doctors are supposed to do what's best for their patients. And that's what my dad taught me. He was a doctor. And he's always told me, you know, I remember when I was a little kid, I said to him, Dad, you're so successful. And what I mean by successful is not money, but like patients loved him. He had a great reputation. And I said, how do you get to be so successful? And he said, take great care of the patients. Ah, why am I seeing bubbles again? Here. By the way, the bubbles, they come from cavitation from the laser, and they're only supposed to show up when the flow is slow. So I have to have a talk with them. No, but in all seriousness, we're trying to work out the flow issue. And it seems to be okay. Yeah, so my dad said there's no magic, you just take good care of the patients. You do what's right for the patients. That's what he told me. And I remember that as a kid, literally 7 years old. And when I became a doctor, I thought all the doctors did the same thing, to be honest with you. I think a lot do, but unfortunately there are some bad actors out there who don't. So here's what I would say to you. The problem is at the university level, because this technology is not being taught at the university level. Okay? But the reason is because there's so much implant companies like Medtronic and Johnson & Johnson and DePuy and NuVasive and Alphatec, these big multi-billion-dollar companies, they are making sure that they are still involved in the spine surgery financially by training all the new surgeons on their screws and rods and cages technology, and making sure that when they leave their training after 7 years that that's what they do. And I was no different, by the way. I was the same way. I left my training at the University of Florida in Gainesville, top neurosurgery program in the country, when I applied. And I was taught to do spinal fusion, complex spinal fusions, artificial discs, laminectomies, microdiscectomies. Endoscopic surgery was just coming into the brain. Like literally, we were just starting to do pediatric endoscopic spine surgery for hydrocephalus. We would do what's called an endoscopic third ventriculostomy. And we were doing those at our center, at Chan's in Gainesville. She's doing great. Yeah, just let her know everything's going well. So the whole concept of endoscopic spine surgery was new, but unfortunately it hasn't picked up because of the fusion stuff going on. And all the money that these departments of neurosurgery make from doing fusions.
Dr. Deuk, you have time for another question?
Oh yeah, I have plenty of time.
All right. We have a viewer on YouTube that asks, can the laser remove a bone spur?
Hold on one second. This is the most painful part of the surgery for her because I'm in the outer fibers of the annulus. I'm right where all the nerve fibers are. So, you know, just keep that in mind as you control her pain. And I need about 5 minutes and I should be done, is what I'm expecting. All right, sorry about that. The question was...
Can the laser remove a bone spur?
Can a laser remove a bone spur? The answer is 100% yes. Very easily. As a matter of fact, folks, the laser can remove a bone spur easier than a metal instrument can remove a bone spur. Okay? The laser is able to melt steel. And just the last surgery we did, the cervical, I was removing bone spurs left and right. So if you go back and look at that, you'll see what I'm talking about. But removing bone spurs is easy. Whoa! She just coughed. Amazing, huh? All right, there's a piece of herniation right there. Come on, pay attention. Be ready. I'm going to see if I can grab that. So I always get that question about bone spurs. Bone spurs are very easy to take away with a laser. As a matter of fact, we remove bone spurs when at 20 watts. 20 watts of power. Okay? This laser can do 100 watts of power. We, at 20% of the power of our laser, we melt steel and we remove bone spurs. Oh, there's a piece of herniation just came out. You all understand that? That's how powerful the laser really is. Honestly, I'm a bit surprised that we still have these conversations about what's going on. Your hand is not letting me take the laser fiber the way I need to. Yeah. That's better. Yeah, I don't know why we still have these conversations about lasers and bone spurs, but somehow the internet or somebody out there is feeding people misinformation. I don't know where the source is. I'd like to know the source so I could address it once and for all. But definitely the laser is much more powerful than a bone spur. All right, so we're just about done. This is fat right here. I'm really just trying to get far enough back to make sure I get all that herniation out, okay? And this is all scar tissue right here, by the way, from the herniation, in the annular tear, from the herniated nucleus. She doing all right? Stand by. Let me have that. So again, it's a combination of laser alternating with grabber. And the grabber, we have a name for it. It's called a pituitary rongeur. Okay. There's some herniation. Come on out. So all this herniation is literally sitting up there in the roof of my approach, of the spinal canal, and I'm like getting it off of the nerve. And it's not coming out as one big piece. It's coming out in a bunch of little pieces. And I have no control over that. That has to do with the anatomy of the herniation itself. And believe it or not, everyone's herniation is different. Some people have a herniation that is like one big lump, and other people have a herniation that forms over multiple events, where they have basically herniated multiple times. So it's like a packet of herniated material rather than just one big one. It's kind of like when you go fishing, right? Sometimes you get a big fish, and then sometimes you get a bunch of small ones. And there's no way to predict what you're going to get, unless, of course, you have a giant hook and you're using a giant bait fish, which you know you're not going to get small fish. But that's not how it is with spine surgery. We go in here to take out the herniation is like fishing, but not knowing the size of the fish you're going to get. So there's no way to predict that. Okay, like I said, getting very close to being done, but the herniation just keeps coming. I may have to use the laser one more time. I'm kind of at the back of the disc now where the herniation is the worst. And all these things, come on, man. What do you think I do when I take this out? Do I look at your hand to see if you wiped it off?
No, sir.
Huh?
No, sir.
What am I doing?
Looking at the herniation.
Yeah, I'm planning my next attack, right? So when I have to stop and look at your hand, that takes me away from the surgery. Is that what I want?
No.
Nope, you're correct. So start acting like you understand what I'm doing, right?
Yes.
And responding appropriately. Now, she's a tough herniation to get because it's over the center. Like, not center of the spine, but it's kind of like more towards the center. It's not so much foraminal. It's called paramedian or paracentral. And what that means is that the herniation is literally not in the foramen, but just to the inside of the foramen. And that's what I've been working on here, is getting all of that herniation out. And I want to get as much as I can. As a spine surgeon, you're never going to get 100% of every herniation. The goal is to get as much as you can safely to get rid of the patient's symptoms. That's the goal. So, laser. You have to have that ready. You understand? All right, let me have that laser. We're quite literally in the back of the disc, right at the root of the herniation, right where it came out. You can see the pink thing right there is the vertebral body. That's L5. That's S1 down there. And we're right between L5 and S1. And I'm trying to reach over as midline as I can get. Let me see. Uh-huh. Okay. This looks pretty good. Let's see the grabber again. Okay, laser. And I can never tell how long a surgery will take ahead of time. So we always just have to be prepared to stay as long as it takes to get the job done. Again, that comes down to professionalism. And this is all just Luis, keep an eye on the tube right here. This tube. I just don't want it going in. I need you to kind of push it this way.
Yes, sir.
Just slightly.
It's good there?
That's good, yeah. That would be a big help. Thank you.
You're welcome.
Let me see. Uh-huh. Good. That's being prepared. I like that. I still feel like there's more right there in that roof. Yeah. Laser.
Just gonna lighten her up a little bit, doctor.
Lighten her up. Yeah. No worries. Thank you, Luis. So she had her symptoms start a year ago, back in August, in her leg. Before that, she had her back pain. And unfortunately, when you wait on surgery, it allows more scar tissue to form. And that more scar tissue is really bad. And that's what I'm dealing with right now, is that scar tissue. We would have been done. Laser. Take it. We would have been done by now if she would have gotten this done right away. So while everybody thinks, oh, wait on surgery, that's not the right answer. If you have a herniated disc and the pain lasts longer than just a few weeks, she okay? Yeah, no problem. You lighten her up, whatever you need to do to be safe. I'm just chipping away at this scarred up herniation. Now my point is, don't wait. Get it fixed. Get it fixed right away. Huh. Well, there's a piece of herniation. Oh, there she blows. Look at that. No, you're not going to grab it. You're going to flatten out your hand. Look at this here. Can you see it? Light on?
Yep, I see it.
How well do you see it?
That's a lot better.
Yeah. See it? That's a big herniation right there. That was sitting in the roof, causing a lot of scar tissue. A lot. Oh, happy days. This is the most painful part because we're taking the biggest pieces, come on, of the herniation out. What? What do you mean just a second here? Beautiful. All right. Yeah, sorry this taking so long, Doc, but there's just, come on, pay attention. Huh? Is she okay? I mean, I could end now. I feel like we've gotten a lot out. But this is the more painful part of the herniation because it's peripheral, where all the pain fibers are. Laser. Again, this is a battle with a behemoth that is a mass of herniated disc and scar tissue. You can keep her light, whatever you need to do. Just about done here. I want to just zap a little bit more. Is she okay? You just can start bringing her around. Mm-hmm. Let's see. Grab her. Laser. You okay? Good. Just a lot of secretions.
We have another question.
Yep. I'm going to wrap this up in 1 minute.
Okay.
You're going to ask the question.
Yeah, a viewer on Facebook wants to know, is there a long waiting list for the surgery if you live in another state?
There's not a long waiting list because the recovery is so fast, the surgery is so fast that we're able to get this done pretty quickly. So if you're interested, submit your MRI, let me review it, let's talk, come up with the best treatment plan for you, and then when you're ready, you come out and get it done. Okay? But the person to talk to is Joe. Joe does all the scheduling of all the surgeries. All right, I think that's it. For those of you who want to know, the numbness that people have from the nerve being pinched so badly, that takes about a year, 6 months to a year to go away. Irrigation. Yeah. And then if somebody has weakness, about half the patients will wake up, the weakness is gone. The other half of the patients, it takes about a year for that weakness to completely, improve as much as it's going to improve, basically. Alrighty then. We're done. She did really good. You did good. She only had one bad disc, L5-S1. It was herniated on the left side, causing back pain and a pinched nerve. We just fixed it. We're going to put a stitch in here and we're going to put a steri strip. Thank you, everybody. You all did great. Good job. Flynn, you did good. All right. You're fine. Just lay still. All right, go ahead and type up your questions for me. I'll come.
Disc herniations are a common cause of chronic back pain.
Cervical laser.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small
L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative.
Hello everyone, welcome to the post-op interview with Dr. Deuk. He is making his way over to the recording center. He is just stopping by to check on the previous cervical DLDR patient. Please type up your questions for Dr. Deuk. He will answer them all live in the post-op Q&A. Meanwhile, we'll be watching some videos here of testimonials of previous Deuk Spine Institute patients. Please stay tight. Dr. Deuk is on his way.
Inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone.
And leave anything in there. It's all natural. Are you glad you did it?
100% glad I did it. Yeah. I tell this story all the time. Everyone goes, oh my goodness, you had back surgery. Are you okay? I can't believe, how are you walking around and you look so comfortable? And I tell them, I don't have anything in me. and I tell them how the surgery went, and I don't mind showing them the video, and they're blown away. And so I often share your website and number with many people.
Thank you. Dr. Deukmedjian here with one of my patients who actually happens to be a musician and is here in the local high school, right? A very large high school for that matter.
Yep, absolutely. The largest in the district.
Largest in the district. And you have how many members in the band?
160.
160 students in the band, and he is the director of that program. Tell me about your back problems before we did your surgery.
I was an active runner and exerciser, and I was out, on a very long run, 15K, and I noticed a pain running down my leg. I thought it was due to poor stretching and not enough stretching, so I increased that. It wasn't going away, which was a red flag indicator, and I saw my doctor, who then recommended an MRI to see what was going on. And it showed the herniated discs, the L4, L5, L5-S1, who then recommended me to go to another center to receive back surgery. To which, and I had told you before, my wife saved the day and found you guys.
They usually do. The wives usually do. They keep us out of trouble.
Yes, she often does. So, when I came to see you with that same problem, with the pain shooting down my leg, I would say at days, 9 out of 10, I would have to call off of work, sit at home, or lay at home, honestly, just to stay off of it because the pain was so great.
Yeah.
Yeah.
So it really had, the pain in your back and down your leg had a really bad effect on the quality of your life and your ability to do your job. And what did the other center, by the way, what did they recommend in terms of treatment for you?
A fusion.
A fusion, right.
Yes.
So you didn't want a fusion.
Absolutely
You didn't want
not.
a fusion. You didn't want to lose the natural movement from your lower back. And you found out, your wife found out about our laser surgery, which preserves movement by not fusing. And we don't put anything in your body and leave anything in there. Yeah. So your back pain that you had before surgery, which was done 6 weeks ago, by the way, how much of that pain do you still have?
0.
Gone.
0.
Cured.
Yes.
Awesome. And the leg pain?
It is gone. Yeah, the pain shooting down my leg has completely gone away, and it is wonderful to be able to climb the bleachers in the stadium, to get on my podium, and to be able to play my saxophone comfortably.
Awesome. Well, congratulations. You had the courage to do the surgery and have the laser surgery repair your disc, and here you are 6 weeks later doing fantastic. Please tell your wife, give her my best regards. Okay?
Thank you so much.
All right. I'm Dr. Deukmedjian, and I'm here with one of my patients who just finished having the Deuk laser disc repair, endoscopic laser-assisted repair of 2 herniated discs in his back. And we finished about an hour ago. How are you feeling?
I'm feeling great. I'm feeling much better. Yeah.
Good. And a few minutes ago we were chatting about your symptoms, and you said that you would have a Charlie horse in your leg. Tell me about that.
So, after the pain that was in my leg, as I would do any morning stretch, you wake up in the morning and you just reach and you stretch out your body, and immediately I would feel the Charlie horse pain throughout the right leg, consistently every day. And just to test it out, just to feel what that would be like, I just flex that calf and kind of simulate that, and nothing at all.
So the leg pain is gone.
Gone.
And then what about the pain in your lower back there? Do you still have that pain?
That pain is gone.
Cured.
Yeah. Cured completely.
Awesome. I know you're a little sore from the surgery.
Yeah.
So why did you decide to do the Deuk laser disc repair as opposed to a fusion or something more invasive like that?
Well, my physician recommended me actually to send me to a place that I will not name, but to get a fusion surgery. And we looked into reviews and whatnot, and my wife, God bless her, she said, let's look elsewhere and look for places with the right kind of reviews. This was the first place that showed up with the best reviews. So we immediately had that consultation with you, and everything that you said about laser disc repair and what it would do was exactly what we wanted.
Good. Yeah, I can't tell you how many times I hear that story about the spouse saving the day and doing the research. So what's it like for your wife who has to live with you being in pain? You're such a healthy guy. You're really active in the community. You've got students. You're a musician. I mean, what's it like having to deal with, seeing you and your quality of life basically robbed from the back and leg pain? What is that like for her, do you think?
That's tough because she's already a mother of two, and just being a caretaker and having to step up and do all the things that two parents need to be doing at home on her own on days where I can't move or I can't function because the pain is so bad. It can be really stressful because it takes two. And so now that we'll be able to do this together again, it's going to be amazing.
You will, but you have to let your back heal so we don't re-injure it, right?
That's correct. Yes, absolutely.
But washing dishes, no problem. You can start tomorrow.
We can fold laundry and everything.
Yeah, I mean, one thing that chronic pain does is it literally robs people of their dignity. And I think that's the best way to say it, because human beings are social creatures, and we interact, we work together, we collaborate together, we assist each other, and we all work towards common goals. And when you're married or you have kids, you have other people dependent on you, you really, if you're in pain all the time and you can't be active, you're always psychologically you're down, physically you're down, and you don't want your kids seeing you in pain and suffering. So sometimes it's easier just to take a back seat, and that's not how you want your children remembering you.
Right.
So back pain's a deep thing. A lot of people don't understand it. They just think it's pain on the surface, but it really goes deep into interpersonal relationships and dignity.
Absolutely. Yeah, one of the best advice I ever got was it's not always 50-50, and sometimes it stretches in your marriage, that 80-20 and whatnot, and back and forth. And for the next year, it's going to be leaning heavily on my wife, but I know that after that, I'm going to be able to get on the floor with my boys. I'm going to be able to throw the ball around with them, and I'm going to be able to take them to wherever they want to go and play at the park with them, and I can't wait.
Good for you.
Yeah.
So tell me just a little bit about your being a musician, and what are you looking forward to being able to do? Don't say lift the piano, whatever you do, okay?
Right.
Because we know that's how all this started 6 years ago.
Yes.
But what are you looking forward to? How did this pain affect your job, your passion, your love for music?
I'm on my feet sometimes 12 to 14 hours at a day, and within a few hours of just being on my feet, I can feel that pain. And knowing that I can go through a full day and being able to function properly, being able to pick up my saxophone and play comfortably without having to worry about any pain, it means the world to me.
Yeah, it sure does. I mean, as a musician, you're totally focused on playing that piece. You put everything into it. You got the music going. You got to keep up. You have the right tempo, the rhythm, and pain can be a massive distraction, right?
I have an anecdote of that. I mean, I'm sitting in a rehearsal playing and having to make sure that my brain becomes more focused on how I was sitting constantly to keep the pain away so I could play. And now I can focus on the more important things, which is the music making.
That's wonderful. We call that fear avoidance behavior. And what it means is moving a certain way, doing a certain thing, you're afraid. You have fear of doing that because you know it's going to bring on the pain. And so you're focused, part of your brain's just focused on avoid the pain by avoiding certain movements. It's a distraction.
Yes, yeah. And I look forward to not having to think about that again.
Well, congratulations.
Thank you so much for everything.
You're welcome. My pleasure. Hello, Dr. Deukmedjian here.
Deuk
with,
Laser Disc
Deuk
Repair,
Spine Institute
a
in
comparison with
the
traditional
Space
spinal
Coast of
fusion
Florida,
surgery.
just near Orlando. And we're just wrapping up our Canadian patient who is from Toronto. She's had back pain for years, and just in the last year, she started to get left leg pain, horrible pain. She had sciatica. It came from a herniated disc at L5-S1. She traveled from Canada to Orlando, Florida to be at the Deuk Spine Institute, where she knew the very best surgery in the world could be done, minimally invasive, with no damage to her spine like a microdiscectomy or laminectomy causes. She also didn't want fusion or artificial disc because those are traumatic surgeries that are highly invasive. She went with the Deuk Laser Disc Repair. We just finished her surgery. I have to say it went very well. She'll be getting awake in the next 30 minutes, and then she'll be able to go back to her hotel with her mom shortly. But I do want to say our first surgery, the cervical laser surgery, is ready to go home, and he is literally almost doing jumping jacks because he's so happy. The strength in his arms has come back. So we're going to go after this and do a live stream, or actually a recording, I guess, and then we'll broadcast it later today or tomorrow. All right, what questions do we have?
Okay, so we have a surgeon in the chat, and he wants to ask, how can you handle with laser and transforaminal approach for canal stenosis and thickening of the facet hypertrophy?
That's a great question.
Hypertrophy,
Coffee,
so,
please. Okay, sorry, I just had to put an order in for coffee.
Did you understand that?
I understood the question. No, the surgeon is correct. So let me show you what he's asking, or he or she is asking. I don't know if it's a male or female. But great question. Let's just use this foramen here, okay? Let's pretend this is L5-S1 and the herniation is right there. So the nerve root comes out here underneath the pedicle and goes down the leg. If the pressure on the nerve is from the front, the herniated disc, then I can do the transforaminal surgery, get into the disc, and remove the herniation, and the nerve root will be decompressed. However, this surgeon is saying, what if it's this joint back here, the facet joint, that's super big, enlarged, and it's crushing the nerve root? And now you're going in transforaminal, you're fixing the disc. The answer is I can turn my scope around and I can actually drill off the facet joint. And what you'll be drilling is a hypertrophied superior facet. And whatever the arthritic capsule or synovium is, you could remove all that. All you got to do is come out to the edge of the disc and flip your scope and look backwards, and you could start removing that with a drill. Did I do that? No. Can I do that? Absolutely. But I will tell you this, it's rarely done. I rarely need to do it. Why? Because most spinal stenosis that's symptomatic, in my experience, comes from the disc and disc osteophyte from an anterior compression. Now, I want you to understand something. The surgery you watch and the surgeries I do, I don't just do for pinched nerves. Okay? Pinched nerves do not cause back pain. Pinched nerves do not cause neck pain, ever. Pinched nerves cause leg pain, numbness, weakness, and tingling in the legs. They do never cause back pain. Back pain comes from the annular tear, and that's what I'm fixing with my surgery. So my surgery, the Deuk Laser Disc Repair, always involves the actual tear in the back of the disc and the annulus. It's not just about decompressing nerve roots, it's about repairing the tear and getting rid of the source of inflammation. That is what makes my surgery unique and different than all other spine surgeries in the world, because I published in 2012 as part of the Deuk Laser Disc Repair, what makes it unique is the annular debridement, cleaning up the annular tear, getting rid of the source of back pain and neck pain. But great question. It's not a problem, though, to turn the scope around about 90 degrees and actually drill away the facet joint itself that's hypertrophied and facet capsule, doing a foraminotomy and opening up the space for the nerve root.
Okay, and that's it.
Hope you enjoyed the surgery. We're about to go video my last patient, the 2-level cervical Deuk Laser Disc Repair that had a prior fusion. He's so happy. His arms are working again. And like I said, he is an anesthesiologist, doctor, so he came here. He didn't want another fusion. Nice.
He just asked another one. He said, is there a chance for reherniations?
Is there a chance for reherniations with the surgery you just watched? Absolutely, there's a chance for reherniation. which is why patients are restricted. They're not allowed to do bending at their waist for 3 months, and they're not allowed to carry or lift anything more than 40 pounds in the first year. If you follow those restrictions, no lifting more than 40 pounds, no bending at the waist for the first 3 months, reherniation will not happen. Why? Because what I do different than a microdiscectomy, I actually clean the annular tear and debride it. That way the annular tear can reheal, and it does. It just takes time to do so. With a microdiscectomy, you're not debriding the annular tear. There's a lot of grunge and material in there. It doesn't heal. That's why microdiscectomies have a high reherniation rate. All right, thanks everybody. Thanks for watching. We'll see you next